Today we will be talking on non-invasive ventilation, which is abbreviated as NIV. So why it is called non-invasive ventilation? Because you don't do any type of invasive procedure, like you don't insert any endotracheal tube and you don't make any tracheostomy. Okay, you provide ventilation through some interfaces that is simply applied on the either nose or oral cavity, and you provide ventilation. That is called non-invasive ventilation. So obviously you know what is invasive ventilation. If you provide ventilation through tracheostomy or with endotracheal tube inserted, then it is called invasive ventilation. So there are some circumstances where we need to use NIV, and some scenario where we need to prefer invasive ventilation. So we will be talking on what are those scenarios, clinical scenarios where we need to prefer one over the other, and what are its advantages and what are its disadvantages. Advantage, disadvantage of NIV. Okay, and how do you do setting in NIV, and how do you modify the setting based on the clinical status and status of the ABG of the patient, and what are the complications you can anticipate from NIV, and during the process of NIV, when to consider changing to invasive ventilation, and when to consider weaning patient of the NIV, and what are the different modes of weaning in NIV. So the topics of discussions are these for today. Okay, so what are the indications of NIV? Indications of NIV. So one is acute exacerbation of COPD. That is well known, you all know, and gold guidelines suggest that if arterial pH is 7.35 LS and PCO2 greater than 45 mmHg, this is one of the indications of NIV in acute exacerbation of COPD. Or even if patient does not meet ABG status, but patient has increased work of breathing despite supplemental oxygen, then we can consider use of NIV. So one is acute exacerbation of COPD, another is cardiogenic pulmonary edema. In this status, we initially prefer CPAP, and if patient's status does not improve with CPAP, then we can go for NIV, bilevel positive air pressure. Okay, so one is acute exacerbation of COPD, another is cardiogenic pulmonary edema, third is asthma. If patient's status is not improving despite using supplemental oxygen and medical management, then we can consider NIV in asthma as well. So what do we see here? These three indications, those are all indications in acute care setting. Acute care setting means maybe emergency, ward, ICU. Okay, and there are some of the indications where we need to use NIV in chronic care setting. So chronic care setting means like you can use in NIV in home or nursing homes. Okay, nursing home we can also use NIV. So what are those conditions? Like in stable COPD, if CO2 status is arterial CO2 is greater than 55 mmHg. Okay, or nocturnal hypoventilation, like in obstructive sleep apnea, central sleep apnea, if saturation becomes less than 88% for greater than 5 consecutive minutes. This is one of the indications of NIV in chronic care setting. Another is restrictive thoracic disorder. Restrictive thoracic wall disorder leading to chronic respiratory failure. In this condition also we use NIV. So we use NIV in both acute care setting and chronic care setting. So what are some of the conditions where we should not use NIV and we should directly go for invasive ventilation? Like if there is immediate requirement of intubation, if you see that patient needs immediate intubation, like patient has collapsed with hemodynamic instability, okay, in that condition if you think that clinically if you think that patient needs intubation, then would go directly for invasive ventilation rather than trying NIV. Or patient is unable to protect airway. So this may be due to low GCS, patient may be agitated, unconscious due to low GCS, okay. Or or unable to clear secretions. Like in patients with amyotrophic lateral sclerosis, in those patients is not able to protect his own airway, and if you think that patient has high chance of aspiration, in that conditions also we should prefer invasive ventilation over non-invasive ventilation. So these are some of the absolute indications and contraindications of NIV and indications of invasive, okay. And relative contraindications of NIV include hemodynamically unstable patients, hemodynamically unstable and on multiple vasopressor medications, okay. So even if patient is hemodynamically unstable and vasopressor, we can use NIV. But if critically ill patients, if you think that patient status is not going to improve in short term, then you can go for invasive ventilation. So this is the relative contraindications of NIV and indications of invasive ventilation. So we learned where to use NIV and where to not use NIV. Now you decide to use NIV, then you need to know what are the parts of NIV, what are the components of NIV. So one is interface, another is tube, and another is ventilator. Interface means the component, the device that you apply on the face, maybe nasal mask, maybe oronasal mask, or maybe nasal pillow, okay. Or another is helmet that you cover both head and neck, and you apply the positive pressure ventilations. So those are different types of interfaces used in non-invasive ventilations, and you connect that interface through tube to the ventilator to provide the mechanical breath, okay. So these are part components of NIV. Now you need to know how to initiate NIV. So you decided to initiate NIV. Now how to initiate NIV? So you connect the interface to the throat tubing to the ventilator, and you first do priming. Priming means you don't tie the head gears of the patients, but you simply put the interface over the nose or oronasal cavity, and you start the ventilation. Why don't we initially tie head gear? We want to see whether patient is able to tolerate or not, and initially patient will, if you try the head gear, the patient will throw it out because he does not like it, because you are applying the continuous mechanical pressure on his face, okay. So patient will feel discomfort. So you have to keep your hand, you support the interface, and let the patient adapt, let the patient synchronize with the machine breath, okay. That is called priming. And initially, what you do, initially you set FI to 100%, okay. In machine, I forgot to tell you, in machine, when you start breath, initially you set make a FI to 100%, you can later decrease based on patient need, okay, but initially FiO2 is 100%. And when you initiate NIV, you need to know the some of the terminologies. Why you need to know those? Because you have to do setting of those. Okay, and one is called inspiratory positive airway pressure. One terminology. So this is, let's suppose, trachea, and these are bronchi. Okay, and these are bronchi. So during inspiration, whatever positive pressure is applied to the airway, that is called inspiratory positive airway pressure. And while expiration, whatever the pressure is applied in this respiratory tract, that is called expiratory positive airway pressure. Okay, and the difference between these inspiratory and expiratory is called driving pressure. Driving pressure. Okay. You might have heard the terminology positive in expiratory pressure, PEEP, that is abbreviated as PEEP. What is that? At end of expiration, whatever pressure is applied to the airways alveoli to prevent alveolar collapse, that is called positive in expiratory pressure. Okay, and in the NIV, the same is called EPAP. Okay, expiratory positive airway pressure. We apply to prevent alveolar collapse and to wash out carbon dioxide. Why I am telling you wash out carbon dioxide? You take all my words cautiously because those are important. Why I am telling you to wash out carbon dioxide EPAP? Because to wash out carbon dioxide, the airways should be passing, it should not be collapsed. So if it is during expiration, you will wash out carbon dioxide, and if it is collapsed, then it can't occur because there trapping of those air will occur inside the alveoli. No, and it can't be exhaled out. So to wash out carbon dioxide, you have to increase expiratory positive airway pressure. Okay. And inspiratory positive airway pressure maintains the oxygenation. If patient has hypoxia, you increase IPAP. But see one problem. If you keep the IPAP same, but if you increase the EPAP, because you think that my patient has good oxygenation, but he is not able to wash out his carbon dioxide, so I will increase the EPAP to wash out carbon dioxide. But I will keep the IPAP same. So let's suppose initially IPAP is 10 and EPAP is 5. Let's suppose. So the driving pressure is the difference between that, 5. Let's suppose if you increase the IPAP from 5 to 7, so the driving pressure falls to 3. So if there is low driving pressure, what happens? Low tidal volume goes inside the lungs. And if patient has low tidal volume, what happens? His body is not able to oxygenate, get sufficient oxygen, and the compensatory tachypnea occurs. No, respiratory rate goes high to maintain the minute ventilation. The result of which is increased work of breathing and respiratory muscle fatigue. So, if you increase IPAP by 2, you should also increase IPAP by 2 to maintain the driving pressure constant. Okay, so just don't increase EPAP and keep the IPAP constant, because another problem will occur. So here you understood the term IPAP, EPAP, driving pressure. And another term is called tidal volume, exhaled tidal volume. So one tidal volume is that you inhale, and another tidal volume is that you exhale. Whatever you inhale is not necessarily exhaled out. No. So you have to measure what is the exhaled tidal volume. Because why do you measure exhaled tidal volume? If you don't measure, let's suppose the exhaled tidal volume is 3 to 4 ml per kg body weight. So you are not sufficiently able to exhale out. So that is trapped inside the lung, alveoli. That is called air trapping. And with each breath there is trapping of air, and progressively what happens, the auto-PEEP is generated. That is called auto-PEEP. auto-PEEP is generated. And to counteract that auto-PEEP, you have to increase the PEEP in the machine, or you have to increase the expiratory time. If you increase expiratory time, the time during which patient exhales out, what happens? That the air gets time to pass out. No. So you will either increase extrinsic PEEP or you increase expiratory time duration. Adjust I to E ratio, inspiratory to expiratory time duration. So these are some of the terminologies that you must know. Okay. So after that, let's come to our patient. So I was telling how to do setting in NIV. No, so what I told you that you set initially FiO2 100%, and in that you have to keep IPAP. So initially we keep IPAP at 10 centimeter water and EPAP at 4 to 5 centimeter water. Okay, initially, and we increase this adjust based on the clinical status of the patients and ABG status of the patients. So let me give you one clinical scenario. One 73-year-old male, he is a known case of COPD. He presents to emergency with acute exacerbation. And initially his respiratory rate while presentation was 30 per minute. Okay. And you did ABG and pH was 7.31, PC2 was 56, PO2 was 49 hg. Okay. So this was his initial status. So PCO2 was high, so you decided to keep patient on NIV. So you kept the IPAP at 10 centimeter water, EPAP at 4 centimeter of water, let's suppose, and you initiated patient on NIV. And after 1 hour, what you see, the patient is still restless, agitated. Okay, and the pH has changed from 7.3 to 1 to 7.32 like that, and it CO2 from 56 to 53 mmHg, and from PO2 from 49 to 59 mmHg, and let's suppose CO2 is 90%, and patient is still tachypneic. Initially it was respiratory at 33, now let's suppose it is 24 per minute, and the patient is still restless. Here you see the CO2 is still high. No. So in this case, what additional thing you will check in this patient? I already told you. Tell me. Is this data sufficient for you? Respiratory 24, pH, CO2, PO2, saturation. Or do you want to know anything else to adjust this setting? Yes, you are right. Exhaled tidal volume. What I told you that? You need to know exhaled tidal volume. Whether patient is able to exhale his air or not from his respiratory tract, or is there auto trapping of air inside his lung. So his exhaled tidal volume was 3 to 4 ml per kg. I checked it and it was 3 to 4 ml per kg. Low tidal volume exhaled. And actually it should be 6 to 8 ml per kg at least. No, so it is low tidal volume. So you are saying the thing, it is tidal volume. So in this case, what you have to do? You have to increase the tidal volume. To increase the tidal volume, you know tidal volume is a function of IPAP and driving pressure. Okay. So you have to increase the IPAP. Okay. To increase the tidal volume. And here you can see CO2 is 53, still high. So you have to wash out CO2. To wash out CO2, what you need to do? You need to increase EPAP, expiratory positive air pressure. So let's suppose EPAP you increase from 4 to 6. And let's suppose you don't increase IPAP, keep it 10. So the driving pressure decreases from here 6 to 4. So tidal volume then further comes down. From 3 to 4 it will come to 2 to 3 or 1 to 2 like that. It will aggravate the condition. So you have to increase the IPAP also. Let's suppose you increase it by 2, you should at least increase it by 2 to maintain the tidal volume. So in this condition, what setting you need to make? You should increase EPAP, you should increase IPAP. You should increase IPAP and you should increase EPAP, both to maintain the driving pressure, and you have to, in this condition, you have to increase EPAP to wash out carbon dioxide. Okay, so this is one of the clinical scenario. I give you this scenario to make you understand how do you do the setting in the real life. Okay. So now let's suppose you patient is started and you are doing setting, you are doing fine, and patient is on day 2 of admission of NIV. So when do you consider I need to change to invasive ventilation, or whether I need to wean the patient off the NIV? So you have to watch the clinical status and ABG status. Let's suppose clinically patient is deteriorating. Patient's consciousness is falling down. Initially patient was able to protect airway, but now he is not able to protect airway. He is not able to clear his secretions. Okay, in those conditions, so you can think that he will deteriorate on NIV. I need to do invasive ventilation. I need to insert into tracheal tube and protect his airways. Okay, and so you have to decide clinically, and ABG wise, if you see the CO2 status, in this case what you see, CO2 status was fall from 56 to 53, at least it was in decreasing trend. But let's suppose it is increasing trend, even despite doing settings, it is not getting controlled, then basically go for invasive ventilation, no option, no? So this is about when to do switch to invasive ventilation. Now you should also know when to wean patient off ventilation. So obviously the same thing, you should see the clinical status, you should see ABG status. If it is improving, then you can think of weaning. And in weaning there are two strategies. One strategy is called mask of ventilation, and another strategy is decreasing IPAP. Okay, mask of ventilation means that you put off the mask. You remove the interface and let the patient breathe spontaneously. Patients, if you see in 1 hour, the patient has increased work of breathing, patient is deteriorating clinically. Okay, so you can think that, oh no, this patient is not improving, I should again put the interface and let's switch. So you put off the mask for some time and let the patient breathe, and sometimes you put on the mask, put off the mask, and this way you do weaning. It is called mask of ventilation. And another is IPAP, decreasing IPAP. So you gradually decrease IPAP. Let's suppose your initial IPAP was 14, you decrease it to 12, you decrease it to 10, and come to minimum IPAP and see the clinical status of the patient, ABG status of the patient. If there is no increase of work of breathing, if ABG is improving, then you can consider, oh, now patients can be weaned off the NIV. No. So, and what are the complications associated with NIV? Complications. So complications, you can remember like this. What are the components of this NIV? One is interface. So complications from the interface. Whatever the mask you keep, and you have to keep the headgear tight. So due to tightness, there can be pressure source on the face, wherever there are hard points in the interfaces. There can be, so you have to look for that. And you are giving positive pressure. That positive pressure is not only going inside the trachea, but also going inside the stomach. That is called aerophagia. Okay, so abdominal distension can occur, abdominal discomfort, bloating can occur due to aerophagia. And you are giving positive pressure, so you are restricting the cardiac filling because of the increased intrathoracic pressure. That's why cardiac output falls down. And if patient already has low BP from the get-go, and you are keeping on vasopressor medications, and you are again keeping you are again making the pressure come down because of the increased intrathoracic pressure. So also watchful for BP in patient started on NIV. Okay, so another is what are the complications? One is interface complications, another is through the pressure, whatever pressure you apply on the face, so complications with that pressure. And another is that due to inadequate humidification, there can be nasal dryness and congestion can occur. So you may need to give decongestants, humidified oxygen. So consider those and watch for that those. Okay, because those are common complications: nasal congestion, nasal dryness, and if you just adjust it, patient can be comfortable. So those are minor things, but it matters a lot to the patient's comfort. If patient won't tolerate NIV, then obviously you can think that, oh, no, not tolerating, and I go for invasive ventilation. But if you just simple tweak like this, humidification, decongestant, patient is improved. Oh, so this is a minor thing, but matters a lot. Okay, so don't neglect those things. So what we learned, what is NIV, when to consider NIV, when to consider invasive ventilations, no, and what are the initial settings that we need to make while setting up NIV, and how do we change the settings of NIV during the course of time, no, and after that what we learned, with the case scenario, I gave you the example of the patient and how to adjust setting, and after that I told you about weaning, how to wean of the patients of the ventilation, and when to consider changing to invasive ventilation, and at the last I told you what are the complications of NIV. So with this I like to end this lecture. Thank you.